Good day and welcome to our lecture series and our part 3 on lectures on streptococcal infections. And today we are going to discuss mainly neonatal sepsis caused by group B streptococca. I am Dr. Teke Apalata, a consultant in clinical microbiology. So we will discuss early onset versus late onset neonatal sepsis or disease among children. So this is a part 3 of our streptococcal infection lecture series. Now let me remind you again, this table that you have seen it since the beginning of our part 1 lecture on streptococcal infection. And in today's lecture, we are going to focus on group B beta hemolytic streptococca that we also call streptococca agalactiae. Streptococca agalactiae, it's a group B beta hemolytic, and it's known to cause diseases in among neonates, and mainly sepsis and meningitis among children. So Streptococcus agalactiae or group B streptococca. So we have said that we call it a GBS. So if I say GBS, I refer to group B streptococca. So GBS is one of the leading causes of morbidity and mortality among newborns. And it results in sepsis, pneumonia, and meningitis. So it can cause 3 conditions mainly: sepsis, pneumonia, and meningitis. And GBS is carried in the vaginal and anorectal flora of up to 30% of women. Then when they give birth, then the child will then become exposed or affected, then develop an infection with group B streptococca. So about 30% of women are colonized, either in their vagina or anorectal flora. And this maternal colonization among certain women can be intermittent, it can be transient, or it can be persistent. So some will carry that pathogen, that microorganism in intermittent way, so it comes and goes. Others, it can be persistent. Fortunately enough, although 30% of women can carry these bugs, but the attack rate in newborns is a bit low, because the incidence of early onset neonatal disease is 1 to 2 cases per 1,000 live births. So if you have 1,000 children who are given birth, maybe 1 or 2 will then develop this condition, but it's a very severe, very serious condition. And the mortality rate is up to 20% in the children who are among children who are affected. So what are the risk factors for the GBS transmission? We have 30% of females or women who are colonized when they are pregnant, and when they give birth, there is a risk of transmission of these bacteria from the pregnant from the mother to the newborn child. Now, what are the risk factors that facilitate that transmission of the infection? The first one is that the woman has developed chorioamnionitis infection during pregnancy or during labor, chorioamnionitis. Or they do have GBS in their urine during the current pregnancy. They carry the bacteria in their urine, sometimes without being symptomatic for any urinary tract, without presenting signs and symptoms of urinary tract infection that we call GBS bacteriuria. So if you test their urine, you can find the bacteria there. Or sometimes the other risk factors is what we call maternal rectovaginal colonization. So if you test them, you collect a swab, you send to the lab, you find that they are colonized with the bacteria. Other women will develop a temperature of 38 or greater than that. Some will have a preterm labor or preterm rupture of the membrane around 37 weeks of gestation. So they might have a rupture of the membrane, early rupture of the membrane. Then when you try to maintain them, to push them to reach at least 38 weeks or 37 and a half or 38 weeks, then there is a possibility that they can develop an infection or a chorioamnionitis. There is also another risk factor is previous delivery of an infant with an early onset GBS sepsis. It's also a risk factor, or a prolonged interval of at least 18 hours between the rupture of membrane and the delivery. So if the interval between the rupture of membrane and the delivery of the child is from 18 hours and above, there is a risk that the child will develop a neonatal sepsis with group B streptococcal. Now, what are the indications for GBS intrapartum prophylaxis? So when can we then decide to put pregnant women on prophylaxis so that we can prevent their children from contracting the infection when they will be born? So there are a couple of indications. One is GBS bacteriuria during current pregnancy. And if you do the urine test in pregnant women, because that is recommended to test, to do the urine culture, you find that there is you find group B streptococcal, even without doing rectovaginal swabs between 35 to 37 weeks of pregnancy. So you can already, with these results, you can put that pregnant woman on prophylaxis, from 35 to 37 weeks of pregnancy. Or if the status of this pathogen is unknown within 6 weeks of delivery, and any of the following, like it's less than 37 weeks of gestation and cesarean section delivery is not planned. So you know that this woman is going to give birth. You don't have information whether she was tested or not for GBS. You don't know anything. And there is no plan to do seizure section. So it is expected that this woman will deliver naturally. So then you have to put that pregnant woman on a prophylaxis. Or if there is a rupture of membrane of 18 hours and above before delivery, it's an indication for putting this woman on prophylactic antibiotic. Or if she develops a temperature of 38 degree or greater and no evidence, or with no clear evidence of chorioamnionitis, it's still better to put that woman on prophylactic antibiotics to prevent GBS transmission. Or if there is a positive maternal GBS culture at 35 to 37 weeks of gestation during current pregnancy. Or if you have a previous newborn, that woman has a previous newborn with GBS invasive disease, it's also an indication to prevent the transmission to the current child. So those are a few indications on when to use prophylactic antibiotics. Now, there is what we call onset of labor or rupture of membrane before 37 weeks with significant risk for imminent delivery. Now, if there is a rupture of membrane before 37 weeks, of course, you are going to protect this pregnancy. But you check the GBS status, you test. If the GBS status is negative within the 6 weeks before delivery, then there is no prophylaxis that you can give. But if the result comes positive, you can start this woman on prophylactic antibiotic, and you continue for at least 48 hours during tocolysis and during labor. But if the GBS status is unknown, you can obtain a rectovaginal swab and send to the lab for culture, and you start the GBS prophylaxis. And if no culture grow in 48 hours, you can stop, because it is unlikely that these microorganisms cannot grow after 48 hours. So when is the prophylactic antibiotic not indicated for group B streptococcal? When you have a negative rectovaginal GBS culture at 35 to 37 weeks of pregnancy, it is not indicated, regardless of any other intrapartum risk factors. Or when there is a planned cesarean section for delivery, then in the absence of labor or membrane rupture, so regardless of the GBS status of the mother, when there is a cesarean section that is planned, so there is no need for prophylaxis because there will be no transmission. Or if the previous pregnancy with positive GBS screening culture with a negative culture during the current pregnancy. So the previous pregnancy had a positive GBS screening result, but the current one has a negative screening culture result. So there is no need to put that pregnant woman on prophylactic antibiotics. Now, the recommended prophylactic antibiotic is penicillin G, and you give an initial dose of 5 million units IV, and you can give subsequent dosing of 2.5 million every 4 hours. Every 4 hours until delivery. Now, alternative to penicillin G can be ampicillin with the initial dose of 2 gram IV, and subsequently you give 1 gram IV every 4 hours until delivery. Now, patients who are allergic to penicillin, and but the GBS is susceptible to clindamycin and erythromycin, you can put them on clinda or erythromycin. But those who are allergic to penicillin and high risk for anaphylactic shock, but GBS resistance to clinda, then you can put them on vancomycin 1 gram IV every 12 hours, So penicillin allergy and not a high risk, you can give them cefazolin, initial dose of 2 gram IV. Then subsequently you continue with 1 gram. So this is the prophylaxis. Now let's look at what we call early versus late onset neonatal disease. So that's what you do when the woman is still pregnant. But now, if the woman gives birth to that child, to the neonate, now the neonate can develop an infection. Now, what do you do with neonatal infections? This is what we are now going to discuss in this part. So, invasive GBS disease is a laboratory isolation of Streptococca galaxiae from a normally sterile site in an infant. And this is a neonatal infection because it happens between 0 to 89 days. So within the first 3 months, the child is born. So those are the one we call neonate. So, and that child can develop a sepsis, the child can develop pneumonia or meningitis, Now, we call early onset disease if any of these diseases happens between day 0 to day 6. So within the first week that the child is born, then if the child develops an infection, whether sepsis, pneumonia, or meningitis, within the first week, this is early onset. And what it means is that the child contracted an infection through a vertical transmission. So it means that it came directly from the mother to the child. Before that the child was born, the child was already exposed to the infection, to the bacteria. But the late onset is between day 7 to day 89. So the infection is acquired from the mother. It's acquired from the mother or during birth, or maybe from environmental sources. So that's why it took time for the infection to occur. So this is what we call late onset. So it is important to differentiate early versus late, because the pathogens that are involved in early onset infection, that are mainly group B streptococcal and E. coli K1, are the main causes of early onset. But the late onset, it can be, beside those pathogens, you can find any other microorganism in the hospital setting can be able to cause late onset neonatal disease. So the maternal prophylaxis is supposed to reduce the risk of neonatal sepsis, but it does not eliminate it completely. So there is what we call selective neonatal prophylaxis is recommended when maternal GBS carriage has been documented. We have spoken about that, or the woman had chorioamnionitis, or there are signs of neonatal sepsis in the child are present, then you suspect that. So neonates who appear to be septic, and those who are born to mothers with chorioamnionitis should receive a full diagnostic workup before administration of antibiotic. So when you suspect that this neonate is high likely to have sepsis, you need to collect blood culture, do full blood count, and do lumbar puncture to exclude meningitis. Before you start this child on antibiotics, you need to do a lumbar puncture, collect blood for culture, collect also blood to do full blood count. Okay. So what are the microorganisms that are involved in early onset infection? I say there are mainly those two. We have group B streptococcal is the commonest one, and the E. coli K1 and K5. The two bacteria represent almost 70% of cases. 70% of cases. And the choice of putting those children on penicillin and gentamicin was because of those pathogens. Like your penicillin will cover your group B streptococcal, and aminoglycoside gentamicin will cover your E. coli. But now with the occurrence of high rate resistance of E. coli to gentamicin, especially E. coli that are developing a resistant gene that lead to the production of an enzyme called ESBL, extended spectrum beta lactamase. So they are resistant to gentamicin. So sometimes we recommend that you put the child on ampicillin or penicillin or ampicillin plus amikacin. That will cover your resistant E. coli. So other microorganisms can also include Listeria monocytogenes, Staphylococcus aureus, and Streptococcus pyogenes. But microorganisms that are associated with late onset of infection are mainly your coagulase negative Staphylococcus that are mainly resistant to cloxacillin, so we use vancomycin. And you also have gram-negative bacteria like your E. coli or Klebsiella pneumoniae, Pseudomonas aeruginosa. So that's why you can see we have a combination like your vancomycin for covering your resistant gram-positive bacteria, and you have maybe amikacin for your gram-negative bacteria that are found in the hospital setting that can be highly resistant. So prevention and treatment that I already highlighted, we say that pregnant women between 35 and 37 weeks should receive what we call universal GBS screening. So we need to screen them, collect urine, collect swab, vaginal swab or anorectal swab to see if they are not colonized with group B streptococcal. And if we find that is true, we can put them on prophylaxis. It can be penicillin, ampicillin, or cefazolin, or clindamycin. At least, it needs to start at least 4 hours before delivery. They need to receive prophylactic antibiotics. Then you can also put them on empiric treatment. We have empiric treatment for children, you know, after collecting blood for full blood count and for culture, and after doing collecting CSF to exclude the possibility of meningitis, you can start those children on empiric treatment like penicillin AMPI plus aminoglycoside for early onset infection. And you can use vancomycin and aminoglycoside for late onset infection. And if meningitis is suspected, you can mainly use the third generation cephalosporin to manage those children. So thank you for following this third part of our lecture series on streptococcal infection. And on the first part, we discussed streptococcal infection in general, and with a special focus to pharyngitis, skin and soft tissue infections. And we covered also necrotizing fasciitis in that first part. You can go and review that lecture. On the second part, we focused on post-streptococcal complications like glomerulonephritis and rheumatic fever. And in this third part, we focus on neonatal disease like your neonatal sepsis, meningitis, and pneumonia. So follow us on our last part of streptococcal infection when we will discuss streptococcal infective endocarditis. Thank you and goodbye.